So today I'm going to begin my cardiac assessment with a doorway or end of bed assessment. So here we're looking at the patient's general appearance. This is generally done in the patient's home. So we're looking to see whether they're pale, sweaty, short of breath, whether they've got mottled skin, whether they're well perfused. We're also going to be checking their pulses, so the rate, regularity, strength. We're also going to look for any equipment, so is there any oxygen tubing, oxygen tanks, any medication, so GTN spray. We're also going to be assessing the patient's cardiac history. So first I want to assess my patient's cap refill. So I'm just going to press gently here on the nail bed for 5 seconds. And also centrally. So as you can see, my patient has a nice cap refill of less than 2 seconds, so that means that they're well perfused. They also have nice warm pink dry skin. They don't look to be in any obvious respiratory distress. They're not tripoding. I'm now going to assess their pulses. So we're just going to take a radial pulse. So first of all, we're going to make sure that the pulse is present. We're going to assess the rate, the strength and the regularity of the pulse. So my patient here has a nice regular radial pulse of about 70 beats per minute. I'm also going to assess the patient's carotid pulse. So in an unconscious patient we want to make sure that this is present. So again, it's a nice strong regular pulse. While we're here, we can also look for venous jugular distension. So jugular distension would indicate an increase in central venous pressure. So we would see this in someone with right-sided heart failure, and it would also be present in someone with a cardiac tamponade. So now I'm going to assess my patient's signs and symptoms. So do you have any chest pain today?
No.
No. So if the patient had said yes, we would continue on with our PQRST. So we would want to know what provoked the pain, whether the pain radiates, the severity of the pain, what brought the pain on, what was the patient doing when the pain started, and have they had this pain before. We would get them to describe the pain. So if it was dull and heavy, we would consider this to be cardiac. If it was more sharp and localized, this would be considered non-cardiac, so muscular or a PE. I'm now going to check my patient's breathing. So I'm going to auscultate their chest, front and back, and listen for any signs of cardiogenic pulmonary edema. Just breathe normally for me there. Just get my patient to spin around. So my patient today has vesicular sounds throughout their lungs. If I could hear crackles, especially in the lower lobes, that would indicate cardiogenic pulmonary edema. I'm now going to place a 12-lead ECG on my patient. So a 12-lead ECG is a diagnostic tool that allows us to view the electrical activity of the heart. So obviously in a patient in the real world we would expose the chest. For the purpose of this assessment we will imagine the chest is exposed. So I'm just going to place my limb leads. So for the 12 lead we're going to feel down to the 4th intercostal space on the right side, and we're going to place V1. And the same on the left, so 4th intercostal space. So we're going to go mid-clavicular, down to the 5th intercostal space. And V3 is in between V2 and V4. So V6, we're going to go directly under the armpit, down to the 5th intercostal space. And V5 is directly in between V4 and V6. I will now analyse the 12 lead and end my assessment with a SpO2 reading and a blood pressure.